in mobile phone, their daily schedule of the visit to the community. So what is our lessons? Use of technology enhances the information transfer mechanism and allows system to respond much quickly. As this is our project. We have our research and evaluation division has done a study and showed that the first and second delay has been reduced significantly, and a mobile phone could be one of the reasons there. But initial investment is very high, as you know that the instrument and the devices are high cost. And technological support is not adequate sometimes, because we are also learning and in Bangladesh there are not many agencies who can provide technological support to that we require in this country right now. And coping with rapidly changing technology is very difficult, because we just shifted from Java-based to Android system, so that is very difficult and we have to discard everything we developed earlier. So I think that is a major challenge for us, and that's all for me. Thank you.
Good evening, everyone. I'm Neelu Singh, faculty researcher from the Johns Hopkins University, and I am here to talk about mCare, empowering workers and communities to empower neonatal survival, actually enhance neonatal survival. Sorry about that. So as I begin my talk today, let me quickly acknowledge how privileged I am to share the dais with such eminent speakers from the region, and also to have the opportunity to present some of my learnings and experiences of implementing mCare in the field with a fantastic mix of audience here. So Bangladesh, as we all know, has a decade of success story of enhancing maternal and neonatal outcomes. However, there are some important challenges that still remain. Key amongst them are reducing neonatal mortality, reduce obstetric morbidity, and enhance antenatal and postnatal care coverage. This university initiative for over a decade now has collaborated with the Ministry of Health here in Bangladesh to have implemented these large nutritional and health trials that have demonstrated results and strategies to enhance maternal and neonatal outcomes. A key amongst them is the administration of vitamin A to newborns for reducing newborn mortality by 15%. We cover about 19 unions of Gaibandha and Rangpur district with around 450 square kilometers. Around 165,000 women have been enumerated in Jivita studies for using mobile technology. And we were really encouraged by the quotes that we found from some of the healthcare workers. A glimpse of the mCare history, where we build partnership with the government, NGO partnerships for service delivery with BRAC to provide referral support, formative phase that I just talked about, end user engagement and mapping the workflow of community healthcare workers to the phone with their husband. Women self-reported their SMS literacy status, which I think is very, very interesting. Around 88% of the women said that they cannot send an SMS, and 73% said that they cannot read an SMS. She is kind of the first point of contact for a woman in the community, and they go to the healthcare worker, the Jivita healthcare worker, and ask them to send an SMS.
50 slides. I'll try and cut it down to 140 if I can, but you know, this is just to get you awake. So I have 12 slides. That's the good news. And I have a friend here who's going to keep me in check on my time. So that's another good news. And if you really want to yawn, if you can do it on the side, it will be good, because it's quite contagious. It spreads. Thank you very much. I work with the Bill and Melinda Gates Foundation. I'm reasonably new there. It's my initial foray into the development sector. I'm a career consultant. How this mother is expected to get these benefits over a period of time, and when we look at it from -9 to 24 months. So we say from the time she's expecting to the time the child turns 2 years old. Now, if you look at this process, a lot of it in terms of data is manual in many of the places, both in India and possibly in Bangladesh as well, right? You have registers which move from one place to the other. I've also seen pieces of paper which move from one place to the other. Do their job better, and enabling technology using it is a far, far more rewarding way of getting things done, as we've seen. Sure that they are reasonably compatible, and ultimately they should be compatible when it goes forward. So I'm happy to have more discussions offline, and thank you very much. Happy to be here and be part of this great discussion. Thank you.
Thank you. It is very difficult to present months of work in 15 minutes, but yet I will concise in 15 minutes. Okay. I would like to introduce two people. Already know your people. That one, Dr. Garrett Mahal and Matt Berger there. Though they are behind the project, now they are sitting in front of us. This is a tool actually we developed. Just you can have a look on this. Thank you. So. The first, my thing is, why Drishti? Yeah. Why Drishti? So before going to Drishti, actually what is the need of Drishti? So for that, we need to observe why Drishti is evaluated and innovated. So India is basically a rural-based community, so the health workers has to go to the rural areas and provide services. She has to carry a lot of registers, and there are a lot of registers, a lot of health education material. She has to go to the field level and use it. That is one of the things. Let's see what is issues with the paper registers here. See this paper register, for only RMS here work, you can see like 18 to 21 registers or 25 registers they are maintaining. It's a huge, it's like more of like 5 to 6 kgs of registers they have to maintain. That is one thing. Next, here if you see here, there are these three are same service register, like ANC register, from a single block. So one block, there are different formats of same registers. It is very difficult for a health worker if you transfer from one subcenter to different subcenter to understand these registers. Very difficult. There is another issue is the levels of reporting, like it will go from registered, subcenter, PSC, block, district. There are multiple levels. Now the manual process, what are the main issues is like time delays. Here, there is as a part of service delivery. Now, the female health worker depends on their cognitive ability to remember who are the mothers, who are the child. We have to provide services. It's very difficult. She may miss the services, so that we lose the coverages. Thank you for all.
And the commission recommended actually there are 10 recommendations across 3 major focus areas: better information for better results, better tracking of resources, and also better oversight of results and resources. There are 11 indicators. There are many countries that declared their commitment that they will provide population level data for these 11 COIA indicators. It also says reduce the reporting burden by aligning multi-sectoral efforts, and also strengthen countries' capacity to monitor and evaluate, and also ensure national scale-up, national leadership, and of course ownership of results. But it requires little longer time than we have expected. Lack of coordination, there is scope of improving coordination at the local level, especially different family planning, health, and other NGO workers.
And very nice and successful story. At last, Professor Azad described about why we need to collaborate all the NGOs and governments. So my question is to the plenary that do you have any plan to work with in a collaborative platform? I mean, all of the plenaries, all of the
facilities. My question is about how mechanism that you maintenance of these kind of machine. What happens if they cannot work or
System to some form of technology. The last thing we wanted to do was give them the fanciest of mobile phones available in the market, right? Because we wanted their learning curve to go in a certain way. Having said that, we were also aware that this would mean that giving them things which were probably not the latest and therefore compromising on some functionality which we may want. To give you a very specific example, one of the questions asked was, what's the guarantee that the data entered by the community health worker in the phone is actually entered at the site of the beneficiary? And whether they could be just entering it sitting at their own home or at the clinic, right? So the answer was that, hey, why don't we do some geo mapping, geotagging to that? But for you to do that, you need to have a smarter phone than the phone you had given them, right?
We are in process, hopefully in the next few months, to integrate and scale with the government of Bangladesh and implement some mCare components as a smart registry platform with the government healthcare workers.
And the technical person who develops this software, they have to understand this. So sometimes it's very difficult to find right person who understands this system very well and develops this.
As part of collaboration as a strategy, there are 3 countries are adopting this as a collaborative group as a thrives, like Bangladesh, Indonesia, and Pakistan, as international collaborations. And as a part, India, though we developed for the Karnataka government, still there are other 2-3 states are interested to take this as into their health systems. So the thing is, this is under like research phase, so it has to complete. Then they will see the results, and they're interested to take this into their pictures. And regarding this, taking this listed to the other NGOs. Like most of the NGOs are like focusing on particular domain, like either family planning or ANC or PNC, something like this. So somehow it need this is a continuous it continues RMNCS continuum, it works, but in the future probably we expect probably, and it is like customized Drishti. If we are going to that, and a particular NGO wants only for a family planning module, they can go for and they'll start implementing that. That is open for that.
We have got NGOs, the largest NGOs in Bangladesh as well as in the world. Okay, they provide their own services, all vertical. At the end, the government doesn't know how many pregnant mothers we have and how many of them have got service. BRAC also doesn't know.
Terrific, thanks. I have the pleasure of hosting and chairing the last day of the formal event before the cultural event. So I see these are the enthusiasts in the room who are still here, excited, and we'll try to ensure that this is a lively discussion and debate, and we'll also make this something that's enjoyable, so before you go into the cultural event, you'll have something to also think about. Terrific. So I wanted to start by saying that this is a session on donor perspectives on mHealth and eHealth as development strategies. And I think it's important to note that in this space of health and development, it's important to have a vibrant contribution from a number of different kinds of partners, stakeholders. And those include the donors, the private sector, and the multilateral agencies that can contribute to ensuring the financial investments are going toward solutions that can help the government and the larger ecosystem in health to find success. And so I want to invite a distinguished panel of guests that reflect this diversity, this vibrant diversity that's operating not only in Bangladesh but more broadly, to come up and join us in a discussion. So I'll invite Ms. Alison Baer, who's a Foreign Service Officer from the United States Agency for International Development in Dhaka in Bangladesh. I'll invite Mr. Kelvin Hui, a Senior Advisor, Health Sector from GIZ in Dhaka in Bangladesh. I'll invite Mr. K.A.M. Morshed, Assistant Country Director of Program Support and Communications, United Nations Development Program, Dhaka, Bangladesh. I'll invite Mr. Matthew Guilford, Director and Global Head of Health, Telenor Group, Oslo, Norway. I'll invite Mr. Rahul Malik, Senior Program Officer, ICT, Bill and Melinda Gates Foundation, India Country Office, New Delhi, India. And lastly, Dr. Samuel Mills, Senior Health Specialist, Health, Nutrition, and Global Practice, the World Bank Group in Washington, D.C. in the United States. I want to start by asking each of the panelists one question, and hopefully we'll get a diversity of opinions and perspectives that reflect the diversity of the panel itself. What role does your institution play in the investing in the ecosystem of health informatics? So what role does your institution play in investing in the ecosystem of health informatics?
Yeah, okay, thank you very much, and thanks for the opportunity. What role does my organization play in, okay, thank you. So for the World Bank, as most of you are aware of, our goal is to alleviate poverty. And in the health sector,
and then let's work it back towards how some technology play can help in that. Let's take an example. Maternal mortality rate, right? The MDGs have listed down that we ideally want maternal mortality to come down to X level, right? And every country is obviously not at least India is not at that level yet. So the national plan would definitely have one of the goals as bring down maternal mortality or infant mortality, as the case might be, from here to here. Now, where does mHealth play a role? Very clearly, to do that, you need to start saving lives. Now, to save lives, you need to start making sure that you have access to information about those people whose lives need to be saved. For her to take a decision on how to save that life.
I think that from an mHealth perspective, I think that with high levels of mobile coverage in countries like Bangladesh and across South Asia, I think mHealth has the potential to become the great equalizer in the healthcare equation.
They happen to work, they come right in the middle. So every 2.5 years, there is either a general election or a state election. And like you said, if the person who's visionary moves as a result of that,
just talk about pilotitis and how we've really as a community reflected on and sometimes accused this ecosystem of doing too many pilots.
Perhaps we have enough basic fundamental understanding of the effectiveness of mHealth and eHealth interventions, and now we can make the case that it is sufficiently evidence-based that we can invest more in it. But I do think that in the health arena, we get tied up in this idea that we are only doing what has been proven and at what expense. And eHealth, mHealth might have been a little bit affected by that trend.
Let's say, in my country, if I wanted to lower maternal mortality, the #1 cause of death is hemorrhage. And I told my secretary, you want to correct that, you build roads. Later, by the time they get there, they're in the latter stages of hemorrhage. So that's...
We have another program scheduled right away. I do know as well, though, we have a couple of crests to get out.
Yes, we do. Thank you, Dr. Mel. And thank you again. This was a very amazing panel, for me at least. I learned a lot. So we do have crests to give out, but this time, since we are seeing some familiar faces, this will only be for the new faces that have just come to the stage now. So if Dr. Mel can present the crest to Ms. Allison Bear. All those big words, the institutionalization, operationalization, interoperability out and just have some nice relaxation. We encourage you to stay with us.
প্রেমের শিকার কেমনে বলো প্রেমের শিকার কেমনে
Thank you, Mr. Chair. Good afternoon, ladies and gentlemen. At the outset, I must say that this is not really a real mHealth intervention. We did some cohort study. We used a cell phone for our study purpose, and we are just will share some of the experiences what we found with our efforts in using the cell phone. And also you can see that our main area was this early postnatal visits and referral of sick children. So definitely it has some programmatic implication.
Bangladesh, a country of 150 million people, born out of a struggle and turmoil in a bloody war for independence, it was once thought that this country would be forever mired in hopelessness and absolute poverty.
খুব ভালো লাগলো যে অক্ষর দেওয়া যায় না এমনিতেই চাপ দিতেই আসে যায় সব কিছু সামনে তখন খুবই সোজা মনে হলো যে আর কোনো সমস্যা নেই মোবাইল ব্যবহার করতে
A fairly common concern is the availability of power in a country where household access to electricity remains quite low.
ইলেকট্রিসিটি তো আমার বাসাও নাই অফিস থেকে আমাদের সোলার চার্জ দেওয়া হয়েছে সোলার চার্জের মাধ্যমে চার্জ দিই হয়
Community health workers are often challenged to carry heavy loads as they conduct their daily activities, such as drugs, family planning products, and heavy ledgers for keeping records and collecting data.
Mr. Rubaid Khan to the dais, then Ms. Stella Alak, Dr. Ali Rashidi, Mr. Matthew Guilford, and Dr. Mahbub Ali. I would like to invite them to come to the dais here. Thank you. I was told that we'll be compensated for the 30 minutes we lost. So we targeted to finish the session by 11:30. So in that case, all of us at the time, as it is, as allocated to all of us, perhaps what we'll do, because the question and answer session might be very interesting at the end of the session, and I don't think 5 minutes is really adequate for that purpose. So my request would be to the speakers that try to short presentation as much as you can without sacrificing the message I would like to communicate. So that we get more than 5 minutes for discussion. Perhaps at the 10th minute, I mean, if you look at me, I'll signal that you have only 5 minutes left. So that you can conclude within the time frame, if possible, even earlier than that. With this, now let me invite Mr. Rubaid Khan to make his presentation, which is entitled Digital Data Decisions, a Supply and Demand Perspective.
I'm Rubaid. I'm from mPossible Enterprises, and I'm the Chief Innovation Officer there. And the topic of my talk today is development decision making and data. And I wanted to subtitle it with what I call an eternal supply and demand mismatch. So I'll explain that as I speak. So I apologize first of all for not really making this presentation very health specific, and I have a very specific reason for that. So to paraphrase this bit, I'll basically say this in a very stylized way, so bear with me on this. So we try to do good without knowing what will turn out to be good in the context. So we often start off with an assumption, and we go through the entire project without really testing whether that has turned out to be any good. Very elastic. And in an ideal world, what this would have meant is the reduced cost would have meant higher utilization of data.
I'm very excited to be a part of this panel and to see some of the discussion, hopefully that we have time in the Q&A for. So to give an overview of my talk and what it is that I'll be covering, I first want to introduce Dimagi a little bit, for those who don't know, and explain where we are, how we fit into this landscape. And what's been really exciting, I think, to see over the course of this conference, both yesterday and today, as well as some of our partners having the opportunity as well to get up and to talk about their specific experiences. So it's kind of a bit, when we talk about this, it's also, there's a behavior change process that goes on there as well, in terms of getting decision makers to understand, okay.
Assalamualaikum and good morning. This is a very, very auspicious moment, really, for all of us. This is the beginning of a big journey, very big journey, bigger than we can even think of right now. Perhaps we can continue the discussion. This is only the beginning of the journey. What happens if we don't follow a methodology? Things become, we reinvent wheels, things become chaotic. It takes longer, it actually costs more. And a lot of frustration and exponential increase in morbidity and mortality.
And frankly, quite humbling in terms of seeing the amazing work that's being done by folks across Bangladesh. Looking forward to going back and continuing to be inspired by this. And just one stat, if you were to compare the average life expectancy in our Asian markets to the global average, if we were to bring up that expectancy to the global average, we would get about 6.5 billion years of life, which to me is just a tremendous opportunity to add value.
Of the world, and including Bangladesh. The deep blue regions in the map are the countries where DHIS is being used at the national level. And you can see that in Rajshahi division, on an average, in the last month, 10 antenatal care interventions or initiatives from the community clinic. And we can see that there is division-wise variation in referral from the community clinic, but not that much difference by sex.
And kind of discussion it can generate, and for good. I mean, it's really very interesting. Let me conclude by saying that I was personally very impressed with the way the works are progressing. In terms of making data available for decision making. I came from an era when data used to be collected through printed forms and pencil, and then you had rubber to correct all this kind of thing. Then you edit the data manually, then you tabulate them manually, and then you analyze manually, and then you present graphs and other things manually. Compared to that, what we are seeing now is an impressive revolution is happening in terms of data capturing, especially with the advent of mobile technology. And it gives, as you see in all the presentations, it gives a huge opportunity for the decision makers, program managers, even researchers to get real-time data in a much more cheaper way
perhaps with much better quality in my opinion. And the analysis and all the lag period you had in processing data is really taken away. And this is a huge opportunity. but still some of the challenges that some of you are raising is concern about the quality. I mean, this is the beginning of a new platform, beginning a new era of data capturing. And those things will come. I have no doubt that this will generate quality data which will be useful for decision making and policy, even for research, where researchers are very critical in terms of. But I can see a huge prospect with this kind of thing. But I can clearly see the need for partnership between the IT people, the statisticians, the other disciplines who makes data collection, management, quality assurance, analysis, interpretation, and presentation in a teamed way, so that it becomes much more graspable. One can be very easily lost with the data because data collection has become so easy now, so cheap with the mobile technologies. There might be tendency of data overload. And that may also overburden the people who provide those data. Even if not for research, I think we should be careful about how much we would like to burden the people who provide those data. And be very conscious that we only collect those data which are beneficial for them or are meant to answer questions, making decisions which has impact for their lives. Because at the end of the day, data belong to the people who provide them. So it has to be used, and their utilization should be maximized in a manner that their benefit is maximized. I think with this thing, as I said, I came from an era and all these things should do like a magic, which we could never dreamed of. And I'm sure during our lifetime, we'll see that this field has grown much more enormously and will bring much more benefit to the people, especially to the poorest of the poor, living in poor countries. With this note, let me thank the organizers for inviting me and giving me this opportunity to sit around you and to listen to all of you. It has been a real privilege, and I gained a lot, I learned a lot. Thank you very much, and we will thank the speakers for making such an insightful presentation. All of you have done so well, and personally I was very impressed, and so was the audience. So let us give a big hand to the speakers.
Thank you again, Dr. Abat, for the conclusionary remarks. And at this time, we would like to present the crest to the participants, to the distinguished panelists that were presenting. And I ask
to 40% increase just after the voice call given by the Honorable Prime Minister.
the Honorable Minister has arrived, so if you can all please take your seats. We will be starting very shortly, so please take your seats.
So with that, I would like to turn over the microphone to Professor Dr. Abul Kalam Azad to kindly lead the session. Thank you.
Thank you, Dr. Alain. Ladies and gentlemen, I welcome you to this special Bangladesh Ministry of Health sessions. And in this session, we will actually try to highlight some of the E&M health programs which has been undertaken by the Ministry of Health and Family Welfare of the Government of the People's Republic of Bangladesh. And you have already heard there in this program, our Honorable Minister for Health and Family Welfare, Mr. Mohammad Nasim MP, is remaining present as the chief guest. And we are expecting our special guest, Honorable State Minister for Health, Mr. Jahid Malik MP. He will be also joining. Actually, he has gone to the airport to see off the Honorable Health Minister of Sri Lanka. So you understand that there is huge traffic in Dhaka, and he is trying to actually come to join with us at this moment. And we are also very happy that in the sessions we are also with us the Honorable Deputy Minister of Philippines, and Honorable Additional Secretary of Ministry of Health of Pakistan. And the guest of honor in this meeting is our Director General of Health Services, Professor Dr. Din Mohammad Nurul Haq. I am as well also chairing this meeting, but also as the chair, I like to take the privilege of presenting the introduction of the e-health and m-health programs of the Ministry of Health and Family Welfare. After my presentation, there will be 4 other presentations actually which will demonstrate the actually key elements of the e-health or m-health programs in Bangladesh. Throughout the 2-day sessions, actually we had several presentations, and by this time you have understood that what is going on under the Ministry of Health and Family Welfare. And in the afternoon session, after this session, we'll have also other programs that will demonstrate the Ministry of Health programs. But in these sessions, actually we have not theory, rather actually we have taken care to demonstrate some of the activities actually which can actually ensure the accountability of the Ministry of Health and Family Welfare. So with this, I'd like to start my presentation. So actually the e-health or m-health program under the Ministry of Health and Family Welfare of Bangladesh has been started from scratch. And with whatever resources we have, with whatever technology situation available, and we have chosen simple solution. And of course, our solutions are not sophisticated because we did not wait for actually having sophisticated solutions, because sophisticated solutions also actually require skilled developer. And rather than waiting for the skilled developer, actually we have made solutions which can immediately actually improve the care for the citizens of the country. And also we have kept in mind that this should be scaled up quickly across the whole country in the shortest possible of time, and with a view to achieve the geographical equity throughout the country. And whether this geography is small or bigger is no question. Actually, we wanted to reach every citizen of the country anywhere. So this was a look of our office from where actually we implement the e-health or m-health program. But this was the view taken in 2008 March. And during that time, even in our headquarters, there was no internet connectivity. We used paper phones. There was no alternate power supply. Currently, under the present government, the electricity supply system from the national grid